Good evening, everybody. First of all, big congratulations to the organizers for this fantastic event, and a big thank you for inviting me here on this topic of drug-induced diabetes. I have no conflict of interest pertaining to the topic. I am sure we will all agree that in today's days of polypharmacy and the increasing incidence of diabetes, we need to be very, very careful and identify if any particular agent is there which is the reason or cause to get for hypoglycemia in a patient, and we need to identify that and treat as early as possible or stop that agent. The expert committee classified diabetes into type 1, type 2, gestational and other types of secondary diabetes. This secondary diabetes includes various different types of diabetes like genetic defects of beta cell function, genetic defect in the insulin secretion, diseases of exocrine pancreas, endocrinopathies, infections, uncommon forms of immune-mediated diseases, and other syndromes associated with diabetes. The drug or chemical-induced diabetes forms a part of this secondary diabetes. Overall, these secondary diabetes comprise around 1 to 2% of total population of diabetes. And the presentations can range almost from mild hyperglycemia or impaired glucose tolerance right up to severe insulin requiring diabetes, depending on the causative factor, depending on the causative agents, and also on the underlying metabolic status of the patient. So drug-induced diabetes is basically defined as the new development of an hyperglycemic state that meets the definition of diabetes and is due to the ingestion of a drug. These drugs that cause diabetes are basically grouped into different groups according to the mechanism by which they can induce hyperglycemia. Group 1 includes drugs which interferes with the insulin production or secretion. Group 2 includes drugs which block the insulin action. Those which interfere with both the insulin and action come into the group 3. And the group 4 includes drugs which cause hyperglycemia independent of the action of insulin. The commonly used drugs that we see are in group 1 are the beta receptor antagonists, the beta blockers. We have tacrolimus, which is used for post-transplant patients, opiates, difedentin and hydantoin. The glucocorticoids, the older oral contraceptives, the protease inhibitors, which are used in HIV therapy, they come into the group 2. Group 3 includes drugs like thiazide diuretics in a very higher doses, the atypical antipsychotics, cyclosporin. These work on both the mechanism on action as well as the secretion, and they come into the group 3, while the nicotinic acid and parenteral nutrition comes under the group 4. The steroid-induced hyperglycemia is per se one of the most common drug-induced hyperglycemia that we as clinicians face in everyday practice. Because of the various chemotherapeutic effects, because of the anti-inflammatory effects that steroids have, they are used in variety of conditions all over. They are used by all different specialities, and ultimately what happens is after excessive usage of steroids, ultimately the patient comes to the diabetologist with the side effects of steroids. I am sure you all have faced this. Overall, the extent of hyperglycemia induced by steroid ranges from almost 1.5 to 47%. And this is mainly because of various factors. It depends on the type of steroid used, it depends on the dosage of steroid, the longevity for how long it is used, and also and therefore the various factors which are associated with the increased risk of steroids. Overall, all forms of steroids are associated, basically whether it is intramuscular, intravenous, intraarticular or oral, are all associated with hyperglycemia. In this respect, the topical steroids and the aerosol ones are comparatively safer, we can say. They blunt the action of insulin and promote hepatic gluconeogenesis, mainly by a post-signaling defect. It is supposed to be caused by activation of liver X receptor beta involving the phosphoenol pyroxenase enzyme. Overall, what the clinical picture that we see when the patients are on steroids is that there is usually a postprandial hyperglycemia, especially in the initial few days or initial few months, and sometimes they present also with a fasting hyperglycemia or mildly increased blood sugar in the fasting state. But it is mainly the postprandial blood sugar which is a challenge for us to control when the patient is on steroids. Normally we see that the diet and OHAs are inadequate in most of the patients, and insulin is usually required when the patient is on long-term steroids. The beta blockers, the older ones like the propranolol, metalol and atenolol are the ones which are usually associated or thought to be associated with hyperglycemia. Actually, the relationship between beta blockers and steroid is still very, very cloudy. If you see, for years we have been using them, but still we are still worried whether they cause hyperglycemia, whether they blunt the action of insulin. They cause the unawareness, hypoglycemia unawareness. They are thought to contribute to hyperglycemia mainly by impairing the release of insulin from the pancreatic beta cell. The newer the beta receptor, the carvedilol and nebivolol are supposed to be safer, and they do not cause hyperglycemia. There have been studies done with beta blockers which also have shown the increased incidences of hyperglycemia. Like the ERIC study which was done with hypertensives on beta blockers had a 28% increased risk of new diabetes compared to the other agents. There was a meta-analysis done with 55,000 odd patients hypertensives on beta blockers which showed a 31% increased risk of diabetes there. Increased weight gain associated with beta blockers is supposed to be another factor which causes this hyperglycemia. Apart from that, the longer duration of therapy, combination with other hypertensives like thiazide diuretics are supposed to increase the risk of a patient on beta blocker to cause hyperglycemia or diabetes. It was thought in the olden days that thiazide diuretics also does cause diabetes, but with the trials did show that when they are used in smaller doses of 12.5 to 25 milligrams, it is per se safer and does not cause hyperglycemia. And the trial showed that when they are used in a very, very high doses of more than 50 milligrams on a long-term basis, it does cause increased elevation in blood sugar levels. They are known to promote hyperglycemia in some cases, mainly by worsening of the insulin resistance. But the main factor which was thought to be there is because of hypokalemia caused by the diuretics, which interferes with the release of insulin from the beta cell, and that is how it basically is thought to cause increased sugar. The other group which we have to be careful about, or which we are seeing nowadays used a lot, is the newer generation antipsychotics. The newer generation antipsychotics are supposed to be better in terms of lesser extrapyramidal effects, but drugs mainly like clozapine and olanzapine are the ones which have been found to have increased risk of diabetes, especially when they are used in patients with schizophrenia. The schizophrenic patients mainly are also less mobile, they are more having a sedentary lifestyle, increased appetite, they put on more weight. So these are the other associated factors which can contribute to the increased risk of diabetes in these patients. But the development of diabetes in these patients who are on these drugs is a complex interplay. It could be because of the increased weight gain. But apart from that, there are other factors, like there is an anticholinergic effect seen with these antipsychotics. There is some reaction with the serotonin inhibitors. There is some reaction with the 5-HT receptors, which is also thought to contribute to the hyperglycemia. Post-transplant diabetes has already been discussed in one of the sessions earlier, but it is one of the another major area which needs to be concerned about. Cyclosporine tacrolimus has been used in post-transplant patients for allograft to avoid the allograft rejection. Long-term use of these agents along with the steroid therapy of the patients on these have been known to cause post-transplant diabetes. The mechanism of hyperglycemia mainly includes islet cell toxicity, diminished insulin synthesis, and decreased sensitivity of insulin here. HIV therapy has been known nowadays where we use the protease inhibitors form an integral part of the antiretroviral therapy. Drugs like ritonavir have been used in these patients, and they have been shown to directly inhibit the glucose transporter type 4 activity, GLUT4 activity, accounting for the hyperglycemia here. They are thought to induce a stress response also that decreases the insulin sensitivity and promoting the insulin resistance, causing hypoglycemia. Another controversy that we face now is whether statins cause diabetes. That is another area which is of concern. In 2012, the FDA issued a warning in their paper with the statin that apart from the liver monitoring, the patients on statin also need to monitor their blood sugar levels. So this evoked this controversy and the fear that whether they are responsible to cause diabetes. Well, what the trials say, the Jupiter trial which was done with rosuvastatin with 20 milligrams per day in patients with elevated levels of C-reactive protein showed a great benefit in terms of reducing the primary endpoint. But the trial also reported a 26% higher incidence of diabetes in follow-up of less than 2 years. Similarly, in a Prosper study which was done where the mean age of entry of the patient was 75 years, there was a 32% higher incidence of diabetes with pravastatin therapy. But these single drug trials are again controversial. There were trials done in the past, like Voskov's was done, which showed that a protective effect of statin. It showed a protective effect of pravastatin when used at 40 milligrams per day as compared to other statin. So the single trials till now have not been clearly been able to show whether it is really responsible for hyperglycemia or no. But various meta-analyses have been done. Like Satar had done a meta-analysis with 91,000 patients. That it included 13 major statin trials here. And what it showed is it showed an increased incidence of around 9% here in the group of patients who were on high-dose statins as compared to non-placebo. Again, it should be what it showed here that out of the 13 trials which were included in this study, the Jupiter and POSPHA, there were only 2 trials which showed a higher incidence, significantly higher incidence in rate, while out of the other 11 trials, 4 had non-significant lower trend and around 7 had non-significant higher trend. Again, Raj Pathak had done a meta-analysis study in 2009 comprising of 6 major trials with around 57,000 patients. And it showed that 13% higher incidence of diabetes was reported in patients with statin here. The next question that comes to mind is whether it is related to any particular statin, whether this effect of high sugar is pertaining to one statin. So Yamakava had examined the effect of atorvastatin 10 milligrams per day and compared it with Pravas and pitavastatin. And random blood glucose and A1C levels were found to increase in the atorvastatin group compared to the other 2 groups. Similarly, a study was done of atorvastatin 20 milligrams compared with pitavastatin 4 milligrams. And there again it showed an increased incidence on atorvastatin, particularly in women and not with pitavastatin. A Coral study done with rosuvastatin versus atorvastatin again showed almost a similar incidence of diabetes in high sugars in rosuvastatin 40 milligrams and atorvastatin 80 milligrams. So what it also told us that whether it is related to a higher dose of statin. Now in PROVE-IT trial, the patients who had experienced an acute coronary syndrome had a greater increase in A1C if they were treated with 80 milligrams of atorvastatin compared to 40 milligrams of pravastatin. Wattles had reported a higher risk of new diabetes with atorvastatin 80 milligrams compared to placebo, and even when they compared atorvastatin 80 with 10 or 20, it showed a higher incidence of 80 milligrams. So what does it tell us, or where do we stand in terms of controversy of statin? Do we agree that it does cause diabetes? Well, perhaps the statin therapy uncovers diabetes only in people who are at risk. If you see the Jupiter trial, almost more than 70% of the patient had an impaired fasting glucose at the baseline, and almost more than 40% of the patients had metabolic syndrome. So maybe it is causing high sugars more in patients who are at risk of diabetes. Secondly, all the trials, individual trials which showed a high incidence, they were trials which were done not to look for diabetes. They were basically trials done for other purpose, and the incidence of diabetes which was found was more as a observational effect or an association and not a cause, and maybe more trials are required to prove that. There have been theories that some other side effects like myalgia, lack of exercise are also associated in the statin group, which could have contributed more to the diabetes. We do not have any clear mechanism of how this statin causes diabetes. So that is another factor. There have been various theories which have been floated. Like one theory is that it causes a decrease in the adiponectin levels and it loses the adiponectin protective effect which is there. Some animal studies have also shown that there is a abnormality in ubiquinone synthesis. There is a defect in the GLUT4 transporter activity with statins which could have contributed. But we do not still have a clear picture of what is the exact mechanism. And therefore we can say that till we have a causative mechanism exact, or till we are sure the benefits of statin still outweigh the risk which is associated with hyperglycemia, and therefore we can safely prescribe statin still in patients who are prone to diabetes also. Coming to the management part, well, drug-induced or drug-associated diabetes mainly irrespective of the previous diagnosis should be suspected in any newly started patient or who has been started on a new drug, which are in the list of all those drugs which we have mentioned earlier. A proper monitoring should be instituted at the description, and the patient should be evaluated thoroughly time to time. Those who are on steroids, especially the hyperglycemia can be there from the very next day or second day, and they should be monitored properly. Patients on hydrochlorothiazide may not have high blood sugars when they are on smaller doses, but if they are on higher doses, they should be monitored equally. The ADA recommends monitoring of fasting blood sugar for 12 weeks if they are on olanzapine for 12 weeks, and after that they should be monitored annually thereafter. Most of the patients who are having drug-induced diabetes may not respond to OHS properly or significantly, and they may require insulin at a certain point in time to control the blood sugar, especially if they are on steroids. The drug which has caused diabetes, of course, should be discontinued, and something better should be initiated immediately. In case of new onset diabetes after transplantation, what has been recommended is the pre-transplant risk assessment should be done. Monitoring for 4 weeks should be done after transplant also, and after that followed by monthly monitoring for 1 year. HbA1c should not be relied upon in these patients because of the severe anemia that these patients have. Usually the HbA1c may not show a correct picture, and the HbA1c of 6.5 is no longer considered as a diagnostic value for these type of patients. The dose of calcineurin and steroids should be tapered off and switched to a lesser risk drugs. Lifestyle modification, weight loss, all OHAs can be used in post-transplant patients. Metformin to be avoided if the GFR is less than 60 in these patients. And initiation of insulin should be considered in case of failure to achieve a good glycemic control. So to summarize, it's basically a growing concern with the polypharmacy that we all use. It occurs due to various drugs with various mechanisms, and underlying and often unsuspected abnormality in carbohydrate metabolism or a family history of diabetes greatly increases the risk of drug-induced diabetes. An effort should be made to identify and monitor the patients receiving therapy with any of these agents, and the goal is to prevent diabetes and the associated complications. Thank you. In the end, I would invite all of you, next weekend we have a Challenges in Diabetes 2015, our second conference in Mumbai. I'm sure I'll see many of you there. Thank you.